The first and core component of Arkansas's new system is the patient-centered medical home. Medical homes are not physical locations, but a working partnership between a patient, their family, and their primary care team. Well-coordinated care designed to keep patients healthy reduces unnecessary expense, leading to a more affordable healthcare system. Each team is led by a designated primary care provider and includes nurses, care coordinators, and other support staff who actively communicate with each other and with any specialists, hospitals, pharmacies, or community supports that a patient may need. Think of it like a football team. The leader of the team, the quarterback, calls the plays. In the patient-centered medical home, the quarterback is the designated primary care provider who is accountable for managing a patient's overall care and makes decisions that impact quality and cost. In the past, our health system generally did not support a leadership or quarterback role for primary care providers, making it difficult to coordinate care with other providers in order to keep the team from fumbling the ball. This has led to a fragmented and uncoordinated system where things like duplicate tests occur. Not only is this inconvenient and sometimes even harmful for patients, it's a big reason why the cost of healthcare has continued to rise.
As we reflect over the last few years and some of the changes that are being put into place, I'm very positive about the fact that Arkansas physicians have been able to be involved in the process as it's moved forward. I'm very pleased that we are now putting an increased value on primary care, and I think that as we continue to move in this direction, I think we are likely to increase the quality of care that all Arkansans receive. I think that the overall health is going to improve.
Developing successful medical homes that support a quarterback and his or her team requires improving the traditional fee-for-service payment system. Fee-for-service is based on providing sick care, paying doctors for office visits, and for each individual procedure. Earnings are based on quantity of patients and procedures with no financial incentive for quality and cost control. In effect, sick patients are more fiscally valuable than healthy ones, a situation most physicians find frustrating and basically unfulfilling. Arkansas's medical home model is aimed at improving the quality of care patients receive and controlling costs by keeping patients healthy. Preventive screenings, vaccines, and early proactive treatment of diseases like diabetes and high blood pressure not only make for a better quality of life for the patient, they help avoid much more expensive healthcare needs down the road.
To create a medical home-based system, providers are now financially supported with upfront payments to help coordinate care and make improvements to their practices that will lead to more touchdowns for their patients' health. These improvements include implementing a support team to ensure patients get the care they need in a timely way without missing opportunities to keep patients healthy. And they include installing tools for easy access to electronic patient records so the quarterback and team can make and then execute the best calls for patient care. In order to continue to receive these practice support payments, providers must meet certain practice transformation milestones, such as identifying high-priority patients, providing 24/7 access to care, same-day appointments, and integrating the use of electronic health records. Doctors must also meet certain quality targets aimed at improving care and reducing unnecessary costs. These targets include making sure high-priority patients have a care plan in their medical record and that they see their primary care provider at least twice a year. Also included is increasing follow-up care after patients have a hospital stay to avoid all too frequent unnecessary rehospitalizations and decreasing use of the emergency room for non-emergency care.
We've already seen in some of the things that we've implemented that we've seen a benefit. We've started following up with all of our kids whenever we see that they've been to the emergency room. We now get reports from the hospital, so when they go to the emergency room, we follow up on it. And the parents really appreciate the fact that we follow up on that. We're getting them in for treatment that's necessary and hopefully preventing future emergency room visits.
By avoiding unnecessary costs, providers may earn additional bonus payments called shared savings, which further support a shift from sick care to better health care.
To be eligible for shared saving payments, shared by the insurance carrier, providers must meet additional quality targets. These include making sure patients get the right preventive screenings, tests, medications, and follow-ups. These targets are meant to catch problems early and reduce major complications or illnesses. This is good for patients, for the bottom line of healthcare spending, and creates an opportunity for increased earnings attached to the appropriate level of decision-making within the healthcare system, which could substantially increase take-home pay for primary care providers. Primary care transformation is making Arkansas a more attractive place to practice medicine and may influence more medical students to work in primary care in Arkansas. Over time, most Arkansans will have a medical home that offers local access to preventive care and assists patients in proactively managing their health.